postnatal diagnosis of congenital diaphragmatic hernia is made within the initial few minutes of life. The afflicted child will display signs of respiratory distress, scaphoid abdomen, and mediastinal shift. This initial diagnosis is then immediately confirmed by X-ray. In this diagram, we can see an X-ray of a newborn with a posterior lateral defect of the diaphragm on the left-hand side. The abdominal viscera herniating into the thorax are indicated by the red arrow. Following diagnosis, immediate intubation is required, as is insertion of a wide-bore NG tube to prevent dilation of the bowel if present in the thorax. The main method of postnatal treatment, as one might imagine, is surgical repair. This generally has to be carried out within the first 5 hours of life, although, as we shall shortly see, this time period can be extended to approximately 72 hours. Surgical entry is usually via subcostal incisions, although thoracotomy is not unheard of. The abdominal viscera that have entered the thorax are removed, along with any hernial sac present. The diaphragm is then closed, using any native tissue available, or, failing that, alternative material is used. This can include synthetic Gore-Tex material, or flaps of the latissimus dorsi or rectus abdominis muscles. If the defect to be closed is large, the patch will often be secured to the abdominal wall for further stability. It has been speculated that allowing time for the lungs to stabilise before surgery occurs can give an increased chance of survival for the patient. This additional treatment can take the form of 3 main procedures. The first of these is high-frequency ventilation, whereby the ventilation rate of the child is artificially raised to 100 to 150 breaths per minute. This increases gas exchange taking place in the lungs, and has been shown to significantly reduce pulmonary trauma. This technique increases the probability of survival from 67% to 94%. An alternative method of ventilation is permissive hypercapnia. This method acts to limit peak inspiratory pressures in order that lung damage is reduced. The probability of survival using this method raises to 84%. The third option available for stabilising the lungs is known as ECMO. This stands for extracorporeal membrane oxidation, and involves cannulae being placed in large blood vessels of the patient, as can be seen in this picture. Their blood is then pumped via the ECMO machine around an artificial membrane oxygenator circuit. This mimics the action of gas exchange in the lungs, and allows the lungs of the patient to rest. Whilst ECMO is generally beneficial to the patients, it can cause problems with the surgery that follows, due to the anticoagulants used during the process. Specifically, dissection of the native diaphragm tissue may occur, making the use of an artificial patch much more likely. As all 3 of these lung stabilisation techniques are generally very successful, the choice of which to carry out is generally left up to the doctor's personal preference. In the case we see today, Dr. Poirot has opted to use ECMO treatment, followed by surgery. As in many cases, the treatment has been a great success. Thankfully, this case of congenital diaphragmatic hernia has been detected antenatally. This diagnosis can be made using ultrasound and MRI scans. In this picture, we can see an MRI scan of an unborn fetus. The abdominal viscera protruding into the thorax are indicated by the red arrow. The defect is detected antenatally in only 50% of cases. Scanning is often routine, but may have been specially requested. In such cases, symptoms such as excess amniotic fluid present, known as polyhydramnios, has been displayed, and these can often be an indication of other problems to come. Polyhydramnios generally also suggest the prognosis for the fetus is not good. Similarly, if the diagnosis is made before 25 weeks, and if the liver has moved up into the thorax at all, signalling a large defect is present, the prognosis is also poor. A more quantitative, although still imperfect, method of predicting the child's prognosis is by measuring its lung volume and head circumference, using ultrasound and MRI scanning techniques. If the lung-to-head ratio is small, the prognosis is not good. Indeed, if the value is less than 0.6, mortality rates are 100%. Treating the condition before birth is, understandably, very difficult. Whilst it is possible to operate on the fetus to correct the defect, this is carried out at extremely high risk, and is generally only undertaken if it can be seen that the liver has moved into the thorax. In such cases, the risk to the baby's life is so high anyway, it is deemed acceptable to attempt to operate. Alternatively, attempts can be made to stimulate lung growth antenatally in order to improve the infant's prognosis. This at least gives the surgeons an opportunity to wait until birth to operate. Two techniques are under development to stimulate such lung growth. The first of these is application of glucocorticoids or steroids antenatally to promote lung tissue maturation. The second treatment under consideration in this region comes from the discovery that lung hyperplasia often occurs in babies with laryngeal atresia. This is then simulated by careful insertion of a balloon into the trachea of the developing fetus. This is then hoped to stimulate hyperplasia and removed following birth. As with other intrusive surgical techniques, this comes at considerable risk and is again only being trialled under consideration for use with high-risk, liver-up babies. In the case we are watching today, Dr. Poirot has deemed that the baby is at significant risk and thus needs to be operated on. Whilst many of these procedures fail, today's procedure has been a resounding success.